This episode of The Curbsiders is sponsored by the American College of Physicians, ACP. ACP is proud to serve as the professional society for internists and has over 154,000 members. For a limited time, post-training docs save $100 on their first-year membership dues. Visit acponline.org/join and use the code CURB100 to get your discount.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity aside from possibly Kashlak Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Hello, Curbsiders. This is Matt, and this is the first time that we have ever reposted an episode, so I wanted to give an explanation. Don't worry, we actually have a ton of episodes that we'll be releasing this month, but we have partnered with Neph Madness, and starting on March 15th, Friday, first Friday of the March Madness tournament, or the Neph Madness tournament, we will be bringing you 4 Neph Madness-themed episodes. I can't tell you exactly what they're about because that content is still embargoed, but needless to say, they are very useful to the practicing internist, and you are going to think they are awesome. Next Monday, we will be back with a brand new episode with returning guest Scott Matherly, or at Liverprof. He is from VCU, and he gave us a fantastic part 1 and 2 of cirrhosis, but now we're going to actually focus on more of the acute complications and decompensated cirrhosis, what you might see on the inpatient side. It is an extensive conversation with Scott Matherly, and it covers a ton of ground. Cirrhosis has been a topic that has terrified me for my entire career, and now I am slightly less terrified, but still terrified. But we have Scott Matherly to thank for a lot of great information that's going to be coming your way next Monday. So back to the episode at hand. This is as I said, this is our first ever recording with the great Dr. Joel Topf, who would eventually become our chief of nephrology at Kashlak Memorial. And it's just so fun to go back and hear how immediately we hit it off with Joel. Also, just kind of weirdly how the way he was using Twitter and how our conversation about it sort of foreshadowed what has now happened, where Med Twitter is just this great active community of people that are building each other up and sharing great information. And it was just so cool to go back and listen to that. I think you'll really enjoy it. And then let's not forget that this episode had a ton of fun moments and brilliant clinical insights, including our discussion of hydrochlorothiazide versus chlorthalidone, some pearls on hyponatremia, and some mistakes that I was making previously in my practice. Joel gives us his recipe for leg cramps, and we talk about resistant hypertension. Lots of stuff that you can use in your day-to-day practice, and certainly it's good to refresh yourself on this stuff, even if you've already heard this episode. I wanted to include some brief corrections that Joel was nice enough to include on a blog post that he made right after this episode aired back in March 2017 on his site preciousbodilyfluids.com. He said, quote, "I enjoyed the experience immensely, but in an hour of talking off the cuff, I made some embarrassing mistakes. In describing water reabsorption, I said it occurred in the cortical collecting duct, but it actually occurs in the medullary collecting duct. In describing my cure for cramps, I tell the story of Gitelman's and say it is like congenital loop diuretics rather than congenital thiazide diuretics, and it's actually more like congenital thiazide diuretics." And he says, "I mucked up the Mr. Fitz story and how it allowed a head-to-head comparison of hydrochlorothiazide and chlorthalidone. I really oversold what happened," end quote. So just consider those corrections as you're listening to the episode. And finally, I just wanted to thank everybody on our Curbsiders team who has been working so hard. I guess now it's been about a year and a half since we've had all these great people working with us. And it's really just made it so much more fun to do the show. And I think our show has gotten a lot better, having just all this creative talent and brain power and this giant network that all these great people brought with them. So I want to thank them. And I also just wanted to thank the various societies and educational partners that have worked with us. Of course, the ACP has been huge, helping us out, offer CME and mock credit to our audience. So we really want to thank them. And most importantly, our listeners who continue to be our strongest advocates. I mean, I can't tell you how many people write us saying, I tell everybody at my institution that they have to listen to the show. You can't pay for that kind of goodwill, and we love our audience for doing that. We've gained so much through the show ourselves, and we've tapped into this just amazing medical community. I can't tell you personally how grateful I am to be part of this whole endeavor, and so I just wanted to say thanks again, and enjoy this, what is easily one of my favorite episodes of all time on the show. Welcome back to the Curbsiders.
Hello, Matt.
Hi, Stuart. How are you doing tonight?
Salty as ever.
Salty. Yes, that's a good segue to introduce our expert for tonight, Dr. Joel Topf. Hi, Dr. Topf.
Hey, hello.
So, Dr. Topf, you call yourself @KidneyBoy on Twitter, and also have been known to be called the Salt Whisperer. Is that right?
Yeah, I don't think anybody else has ever called me the Salt Whisperer, but lots of people call me Kidney Boy.
I think Salt Whisperer is going to stick.
Yeah, one of the better Twitter names I've heard, definitely in the medical world, probably my favorite one that I've heard. So
Kidney Boy?
Yeah, I like it a lot. I think it says a lot about your sense of humor, and yeah. Once that I was hooked on reading your feed once I heard that. So people should check you out.
So it came from my first year of fellowship. One of the positions as fellow was running the dialysis service. And I felt like a traffic cop. I was like, you get dialysis now. You guys got to stop. We'll get you in a couple of hours. And it was just like directing traffic on Main Street. And I changed my my beeper handle to be Kidney Boy. Da-da-da-da-da. Kidney Boy. And the nephrology nurses just would laugh. They thought that was so funny. And then years later, I was looking on Twitter. I was like, oh, I'll go with Kidney Boy.
It's just great. I love it. Well, so we're really excited to have you on the podcast. You've done a lot of cool stuff that we'll get into some of it. And if not, we'll definitely link to your blog and your Twitter feed so people can enjoy that and check it out. I wanted to ask the question I've been asking recently for people: what are you best known for as a doctor or as a nephrologist?
So I was early into social media. I was one of the first nephrology bloggers. There were just a couple ahead of me. This was back in 2009, and I've been blogging since then. And it really, whenever I go to a nephrology meeting, I always meet people that I've never seen before, but they're like, oh, I've been reading you for years. And it's this kind of weird micro celebrity. It's a lot of fun. But yeah, I think that's probably what I'm most known for. And that has then evolved into Twitter, which is like blogging with people listening. It's a lot more fun, actually. And there's a back and forth communication.
Yeah, if you look Twitter up in the literature, they call it micro blogging. So I guess that's kind of blogging too, technically. But so when you're at a cocktail party and a lay person asks you what you do, how do you answer that?
Well, I tell them that I'm a kidney doctor, and then there's this really uncomfortable silence as they rack their brain for anything to say that would make it all sense to a kidney doctor, and they have nothing, right? Like if you're a cardiologist, like everybody has an uncle that had a heart attack. If you're an oncologist, oh, your mother got breast cancer or you had a positive mammogram. Like there's so many common experiences that we touch with a lot of doctors, and kidney doctor, there's nothing. They look at me like they literally have no idea what I do, when I go to work, and then you kind of explain, well, I take care of dialysis patients, and it's amazing. Like as soon as you say dialysis, everybody knows, oh, there's a dialysis center near where I work, or I see one on my way to work. Like dialysis is actually pretty ubiquitous, and people have a lot of contact with that, but somehow they don't connect that to kidney doctor.
So I recently had the distinct opportunity of reading this wonderful book. It's called The Fluid, Electrolyte, and Acid Base Companion. What's your favorite book?
Yeah, that's it. So This is a Burton Rose's tour de force. It's called The Clinical Physiology of Electrolytes and Acid Base, and it is like I read that book and I was like, oh, this is what I'm going to do for the rest of my life. Like it is so beautifully written. It is so clear. It does such a great job of building that model of how the kidney works in your brain that once you've read it, you're like, oh, I get it all of a sudden. And everything makes sense.
Did you happen to read that before or after you wrote this book?
It was the primary source material for the book.
Okay.
It really was. We bought a lot of electrolyte kidney physiology books to do this.
Okay.
And almost all of them barely got cracked. Like myself and my co-author just became addicted to this book. And this guy Burton Rose, he's the guy who created Up to Date.
Wow.
Right. So I, and I think maybe the most important person to medical education, right, since Osler. Right. I mean, he's absolutely incredibly important. And he wrote this book, and then there was a companion book about just kind of glomerular pathology. And that one, I think, was one edition, and he never rewrote it. But this Fluid and Electrolyte one went through 4 editions. Every one of them is great, and you can date nephrologists by asking them what color their cover is on their Burton Rose.
Huh.
It's a rite of passage in nephrology.
It sounds like the pocket medicine book by, I think it's Sabatine, the MGH pocket medicine book.
Mine's red.
My medical school was red. My residency was green. Now it's like purple.
It's a different color now. I think it's like mauve.
It's even, I don't even know what that is. But just to jump back, because I don't know that the audience was in on that inside joke. So the Fluid, Electrolyte, and Acid Base Companion was written by Dr. Joel Topf, which, and it's free on his website.
Or
and
it's
so you can
available at
download
Amazon.com for $30.63.
Okay.
Which was I think the original cost was $29.95.
Yeah.
We did one printing of it. I think there was 1,200. There's 1,200 printed copies out there in the world.
You can still buy 3 new from $33.95.
There you go.
3 copies available. Yeah. If you send it to Dr. Toff, he'll probably sign it for you.
Okay.
No, I'd be delighted to that.
Sir, what is a great medical app that you can recommend to the audience, or any app?
Yeah. So for me, when I have medical questions, I go to Twitter. That I have a community of nephrologists and doctors that I follow and follow me. And if I have an interesting question, I can pose it to them, and I will get incredible answers back. And they're sophisticated and they're evidence based, or some of them will be opinion based and some will be evidence based. And I call it the answer machine. It's absolutely an incredible resource. It's like I have an entire department of medicine that lives inside my phone. So I am addicted to Twitter. I think it's just the most incredible invention ever. And so that would be my favorite medical app. The other one that I love Flashlight. Do you guys have this application?
Yes.
I think we all do.
I'm like the first one up and the last one asleep in my house, and I am constantly using that thing so that I don't step on Legos, as we were talking about earlier.
That's right.
Yeah.
I use it to look at patients' eyes.
Yeah.
All the time. Patients' eyes, pharynx, wounds, right? Like that application gets used a lot, and it's awesome. I love that I have a flashlight with me all the time, and a bright one.
Yeah.
I want to jump back to what you said about Twitter there and make sure that everyone took in how amazing that answer was, and how everybody should probably be trying to duplicate this and build this network. I think so. I think I looked at it the wrong way. So when I joined Twitter, initially I was doing this for news. I was just following a bunch of news sites, and I was like, oh, this is kind of like I get like 5 different newspapers sent to me. And then I tried to do the same thing with medicine. But you're following people and you can pose questions to them. So it's more interactive and you're all helping each other out. And that is a lot more fun. And also probably you get some answers that you would not get from a textbook or a journal or something.
Yeah, and I had never thought about it like that, to be quite honest. And I think that's completely changed the way that I would look at it.
Do you know, have you and your network just like, have you all published this? I mean, it sounds like something that be publicizing or just like kind of trying to get other people to do?
So in the nephrology kind of cohort, we have really worked on developing a really good network for people to join. What we have is a couple of different events that happen on Twitter to bring people together. So one of them is we do a journal club twice a month. So we did one 2 nights ago on immigrants. There was an article in JAMA Internal Medicine about the experience of immigrants with end-stage renal disease and how do they get dialysis in states where they're not able to get into a chronic dialysis unit. And these people live by getting dialysis in the ER once or twice a week, and they need to be sick enough to qualify for dialysis. And so they're always holding out to the last minute so that they know their potassium is high and their oxygen levels are low. Because the worst thing for them is to go to the ER, get evaluated, and told that they're not sick enough, and to go home and wait 6 hours or 12 hours and come back. And it is such a harrowing story. it was published in a journal, and they'd have a whole method section to go through this narrative, but it's a narrative, and it's absolutely mind blowing. And we had, I think we had 90 people join us on Tuesday night to talk about that article. And lots of people that live in these types of states that take care of these patients, and they could give firsthand accounts of this. Lots of people, we had some people from Central America and Mexico that had other views on this. It was really interesting. But one of the meta purposes of these is to bring everybody together, and you start to follow other people that have similar interests. Right. It's not so useful to follow Beyonce when you want to know about nephrology. Right. You need to have other nephrologists. We want to develop a personal learning network. And the difference between good Twitter and bad Twitter is getting the right number of people following you and for you to follow them. And these kind of events bring people together. We have another one that starts next Tuesday called Neph Madness. And this is a spoof on March Madness. So instead of a field of 64 basketball teams, we have a field of 32 nephrology concepts divided across 8 different academic regions.
And how do you decide who wins? That's crazy.
Okay, yeah. So the obvious question is, well, how do you determine winners? So what we have is 9 members of a blue ribbon panel that vote on every one of the matchups. So there's 31 matchups to go from a field of 32 to one champion. And the blue ribbon panel is awesome. We've got past and current president of the National Kidney Foundation. We have the American Society of Nephrology's she's the director of the graduate medical education. We have a professor from NYU and a professor from Harvard. It really is a star-studded cast. We had a couple of people that complained about it early on. We said, well, if you think you can do better, we'll bring you onto the blue ribbon panel. And this will be our fifth year of doing this. And the hashtag Neph Madness is all over Twitter. And again, it's a great way to build that personal learning network. I met a lot of my friends on Twitter through Neph Madness.
I think this stuff is just so cool. Stuart and I both very interested in medical education, and this kind of innovation is just great to hear. So I guess the last question that we'll ask you in this upfront round here is, tell us something about yourself that we will never forget.
So we kind of touched on it a little earlier. I wrote a book called The Fluid Electrolyte and Acid-Based Companion when I was a resident. I was a med-peds resident, and I had started this project that I thought would take about a year and ended up taking it 4 years. It was myself and a friend from medical school, Sarah Faubel. And so as we were trudging our way through residency, we would get a weekend off, and we would be just buried behind textbooks and a laptop computer as we tried to write this 500-page textbook.
Wow. That's incredible.
Yeah.
That's not a good idea.
Yeah. Well,
that is not how you provide balance in your life.
I think what you were saying to us in the pre-recording, you were saying that your day job, to paraphrase you, was something about your day job feeds you and your night job feeds your soul or something like that. So I guess writing this book was feeding your soul, right?
Absolutely. That's exactly it.
Before we get to the rest of the show, we do have a sponsor. It is the American College of Physicians, ACP, and this is the professional home for all internists. As I said, it's the largest medical special society in the world. There are chapters in every state, so there's lots of opportunities for you to get involved and attend meetings at the local level. One of the best perks along with your membership is a free subscription to the Annals of Internal Medicine and all its multimedia features. My personal favorite is the In the Clinic series, which just does these wonderful topic reviews on things relevant to primary care. Plus, the ACP membership comes along with tons of CME and mock opportunities, and members get discounts on critical resources like MixApp and the annual meeting, which you all should have registered for because we'd love to see you there. Whether it's improving the mock process, lobbying Congress to reduce administrative burdens, ACP is not afraid to tackle policy issues. I am proud to be an ACP member and an internist. I have had great interactions with ACP at my local chapter in Philadelphia, and I have also had the chance to participate on a national task force. The senior membership within ACP is really looking to help promote the careers of young physicians, and I have certainly started to benefit from that already. So no matter what your career stage or practice setting, ACP can support your needs. For a limited time, post-training docs save $100 on their first-year membership dues. Visit acponline.org/join and use the code CURB100 to get your discount. Stuart and I wanted to talk to you about diuretics. It'll we'll touch on various topics, but right. Diuretics and treatment of high blood pressure. And
yeah, so before we get started, one of Matt's favorite questions is always to ask if the guest can paraphrase a topic in a Wikipedia-like format. So in this case, could you give us a Wikipedia-like introduction to diuretics?
Diuretics are selective poisons for the kidney. They allow you to poison very specific elements of the kidney to allow you to influence how the kidney will work, specifically to increase the excretion of sodium, and as a consequence of that, water. And we have a variety of different diuretics, and what determines the class is what aspect of the kidney that they antagonize.
So how much, I guess the part of what I was trying to do in prepping for this was try to remember. So I actually majored in physiology in undergrad, and I'm sad to say that I have lost a lot of the physiology that I knew, because once I became a physician, there's only so much of it that you need to know. Now, if you're a nephrologist, I think it kind of lends to, it lends itself to kind of keeping up with this a lot more, especially renal physiology. So what is the basic renal physiology? Maybe we can go one diuretic at a time that people should know, that they really need to know in order to be able to use these medicines and anticipate how they're going to affect their patient.
So the functional unit of the kidney is the nephron. The nephron starts with the glomerulus, which is just a basket filter, a colander, right? And so it keeps out the protein and it keeps out the red blood cells and white blood cells, so that all you do is you get a filtrate that goes through that. Now, the filtrate that goes through there is incredibly high, right? A normal GFR, call it 100 cc's per minute. Now, we have 5 liters of blood, and we have a normal hematocrit of 40%. So that's 60% plasma, and 60% of 5 liters is 3 liters. Now, at 100 cc's a minute, in half an hour, you would have filtered all of your plasma. You'd be done, right? You would be dead long before half an hour. And so the essential component after the filtering, after the glomerulus, is you need to reabsorb almost all of that water. And somewhere between 95 and 99% of that water is going to be reabsorbed. And that's the primary role of the rest of the nephron. And if you walk through it, the next step is the proximal tubule, and I call it big dumb reabsorption. Not a lot of thought there, but 2/3 of that filtration is reabsorbed. The next step is the loop of Henle, and the loop of Henle is the engine of the kidney. This dilutes the fluid, the tubular fluid. So if you want to make dilute urine, that's what happens in the loop of Henle. But at the same time that it's diluting that fluid, it is generating a concentrated medullary interstitium that allows you to reabsorb water in cases when you're dehydrated and you need to retain water. That is powered by the loop of Henle. Then you have the distal convoluted tubule, And this is where you start to add a lot of intelligence to the kidney. You get, again, additional reabsorption of sodium and water, but this is going to be more finely controlled. And then you finally get to the cortical collecting duct, right? We've all been tubules before there, proximal tubule, loop of Henle, distal convoluted tubule. Now we're at the duct, the cortical collecting duct. And this is the real brains of the kidney, where the final tuning of the fluid is done. Potassium is secreted, hydrogen is secreted, and then you have urine after that. That pretty good summary of where we're going to be.
Yeah, that's great.
Okay.
I think I forgot most of that, but it all sounds very familiar, and it all makes sense. Yes.
Excellent. And so from there, you can kind of get a sense of how things are going to work. One of the things that comes up is that proximal tubule, because it does that big dumb reabsorption, if we had an effective diuretic that would shut it down in the same way that thiazide shuts down the distal convoluted tubule, or furosemide or loop diuretics shut down the loop, we would be dead. It would not be survivable. The only way you can shut that down and survive is if it's just not very effective. And so that's going to be your acetazolamide that's going to work there. Not very effective, because if it was effective, it would be lethal. Right, and you can even think about that in the RTAs, the proximal RTAs or the type 2 RTAs. Again, if they were completely effective, they would be unsurvivable. They're only partially effective there. They only partially will block secretion there. Or it's just because there's just so much happening. 2/3 of filtration is reabsorbed there. It's a huge, major metabolically active area.
So we have these areas of the tubules. We have our loop diuretics that are going to work on the loop of Henle. We have our thiazide diuretics that are
and thiazide-like
and thiazide-like that are going to work on the distal convoluted tubule, right? And you mentioned acetazolamide. What am I missing here? Spironolactone.
Yeah, the potassium sparing, so that's a more late distal convoluted tubule.
And the osmotic diuretics, mannitol, which really act throughout the entire kidney. Sometimes people will point to the proximal tubule, but they'll really work throughout the entire tubules.
Yeah, I guess you could probably put the SGLT2 inhibitors in those too, right?
Right, SGLT2 inhibitors really are proximal tubule diuretics. Absolutely.
It also it acts osmotically too, right?
Well, right. That's how all of them act, by blocking reabsorption. You now have an osmotic load that stays in the tubule, and that osmotic load is going to hold sodium back.
I see.
Right, because when if you walk through the kidney, right, there are no water pumps anywhere. All the water movement is passively following solute. Right, there's water channels, right? There's the aquaporin channels in the cortical collecting ducts, but those channels open, and then water will passively flow down into the concentrated medullary interstitium generated by the loop of Henle. All you've done is open the door, and then the water flows down its concentration gradient.
Yeah.
So I think we can definitely, and we'll naturally talk more physiology. That's a good review of how the kidneys are working. And what we really want to bring this to is where, as providers, we're using antihypertensive agents on a daily basis, and just kind of how we can think about them when we're using them. One of the things that I've been taught, and I just want to verify with you if you think of things this way, but based on somebody's level of kidney function, hydrochlorothiazide versus chlorthalidone versus loop diuretics, you might not have any effect if you're trying to use hydrochlorothiazide in somebody with CKD4, and you really have to think about that. Are there cutoffs for eGFR that you think of when you're using those agents?
So what you've been taught, I think, is that's the dogma, and I think it's a great way to think about this, that you want to use your thiazide-type diuretics down to a GFR of about 30, and that as you go south of 30, you want to start to transition these people to loop diuretics. I think that's exactly right. Though there is research that does show that these thiazides do work at low GFRs. The key is you need to titrate up the dose. You just can't rely on that 25 milligrams of HCTZ that we're taught. You need to use a higher dose. And I've heard at GFRs south of 30, they're talking about 100 to 200 milligrams of HCTZ. I never use those doses. I don't use hydrochlorothiazide. I think it's a lousy drug. I'm a big fan of chlorthalidone. a large part of my practice is hypertension referrals. And a standard move I get when I have a patient, they come in, they always are on an ACE HCTZ combination.
Right.
And they're also, of course, by the time they get to me, they're on a beta blocker and a calcium channel blocker. So I switch them to a ACE calcium channel blocker combination pill that pulls the thiazide out, and then I swap out the hydrochlorothiazide for chlorthalidone. And that change alone gets a lot of patients to goal.
You were saying chlorthalidone versus hydrochlorothiazide. Can you tell us why you like chlorthalidone better? Was there studies that showed it lasts longer, or it's more effective, or is it just kind of obvious when you start using it in practice?
Okay, so it's obvious when you start using it in practice. It is way more effective. And a lot of it just comes from the pharmacokinetics, that the half-life of chlorthalidone, I think, is 2 to 3 days. Right. This is a drug that you literally can use 3 days a week and patients will be fine. So you have that patient who's not real reliable with their medications. Chlorthalidone is a great choice. Hydrochlorothiazide, half-life is like 2 or 3 hours. So that's why, I mean, that drug is going to wear off pretty quickly. It will lower the blood pressure a little bit, but it's just not nearly as effective as chlorthalidone. And so, and in fact, when you make that switch, if you make a milligram for milligram switch from hydrochlorothiazide to chlorthalidone, if their blood pressure is pretty close to goal with the HCTZ, you'll probably overshoot with the chlorthalidone. And likewise, you'll see more hyponatremia and more hypokalemia because it's a more effective diuretic. So you're going to need to be careful. You're going to need to be careful for those types of side effects.
So I was always told that HCTZ was used more often because patients can remember it better, but there's got to be a better reason.
Yeah, so I looked up this. I tried to figure out why HCTZ is so much more widely used. And I was told it was just a much more commercially successful drug in the marketplace.
Right.
That not for any reason, but better marketing, better manufacturing, better partnerships, right? It's the drug that it combines with all the other drugs when you want to get a combination, which is something that's super appealing to patients, right? 1 pill, 2 ingredients. Mm-hmm. People love that. And I wonder if some of that comes from the very long half-life of chlorthalidone. Do you want to mix a drug with a very long half-life with a drug like lisinopril that has a half-life of 6 to 10 hours?
Well, if you're selling pills, then yes, right? Because
I don't know. Pills. Maybe you want to get in a combination pill. Maybe the idea is to get half-lives that are similar. That you want to get pharmacokinetics that are much more aligned.
I was more referring to from a. I mean, you can cut this out of the podcast, but from a drug company standpoint, if I can sell more pills, that means I'm going to make more money, which means I'm going to be able to market more. Versus chlorthalidone, if I'm only selling 3 pills, a week, and that's all it takes, you're not going to make as much money in the long term.
Yeah, that may be it. I really don't know what happened behind the scenes and with pharma to result in that hydrochlorothiazide is everywhere. But I kind of feel foolish that I don't know the name of the trial, but there was a large hypertension trial that started out. It was an international trial, and some countries were using hydrochlorothiazide, and other countries were using chlorthalidone, and they were getting these crazy results. Where the countries that were using hydrochlorothiazide were getting a lot more events. And in the middle of the trial, they said, nope, we're not doing this anymore. Everybody's got to be on chlorthalidone. And so it's one of these great kind of natural experiments where you can actually see chlorthalidone versus hydrochlorothiazide, even though they were never really designed. Well, the trial wasn't designed to put them head to head. Kind of by accident, they did get head to head. And I'll find you the reference so you can put it in the show notes because it's a great example, and there's no doubt about it. Chlorthalidone just whips the pants off of hydrochlorothiazide. That's the drug you want.
Another thing that I've been taught. I don't know if this is true or not. Because of the benzothiazine in the hydrochlorothiazide, this is why you have more of the endocrine side effects. So hyperglycemia. And some of the other endocrine side effects, is that do we see hyperglycemia as often with chlorthalidone as we do with HCTZ?
I'm not aware of endocrine differences with the drugs.
Okay.
In terms of the side effects that I usually worry about, I'm really mostly worried about the electrolyte abnormalities, and I think there are significantly more with the chlorthalidone. But I've not looked at cholesterol and glucose. I don't know. That's a good question.
Dr. Topf, I want to ask you this question. this comes up all the time for me. When I have someone on a thiazide diuretic and they start to have this hyponatremia, sodium's 130, maybe it's 129, 129 to 32, 132 when I check. What do you do with that? I kind of just ignore it. I'm like, oh, they're on a thiazide. That's why it's happening. Does that change anything for you when you see that in your patients?
I'm kind of a ninny. I'm pretty nervous about hyponatremia. I don't like seeing those sodiums. I think 132, I might give it a pass there. But if I see 129, I'm stopping the drug.
Okay.
And probably at 132, I would titrate their dose down. That the dangers of hyponatremia, they're kind of subtle, right? Like that patient's not going to get central pontine myelolysis. That patient's not going to get headaches and vomiting and all that, and cerebral edema. None of those problems are going to surface in that patient. But the two things that we've seen in hyponatremia that are more insidious is these patients get osteoporosis, right? That these patients will start to move sodium out of their bones to compensate for that hyponatremia. And as their sodium moves out of their bones, so does their calcium. They literally will demineralize their bones from that hyponatremia. And the other thing they get is they get increased fall risk. And could you imagine two side effects that would be worse together, both demineralization of the bones and more falls? It's a disaster. And we get, at our hospital at least, we get pretty regular consults for hyponatremia. I love it. I love taking care of sodium. And I can't tell you how many consults we get from ortho, little old lady, broken hip, consult for hyponatremia, sodium 128, 126, right? And a lot of them are on thiazides.
Yeah.
And that's just, you don't want any part of that.
Let's say I have this case in my practice a lot. Little old lady or little old man, they're on hydrochlorothiazide or chlorthalidone at the low dose, and their sodium's 130. Maybe they're already on 2 other blood pressure medications. So taking them off that, it means you're going to have to go to something a little bit more unusual. Maybe you'll use unusual or not your first 3 drugs. So you might use spironolactone, you might use a hydralazine or clonidine or something like that. Because now you already have them on a calcium channel blocker, you already have them on an ACE. Now you're going to have to remove the thiazide. Is it serious enough that you would take them off if they're in the low 130s and and it's going to mean going to one of these other drugs?
Yeah, I think if they are north of 130, I'll tolerate it. In my mind, the line in the sand would be 130. They going below 130 is like, no, I'm not doing it anymore.
Now, follow-up question. When we start someone on a thiazide diuretic, how soon do you want us to be checking, and what's your practice? How soon should we be checking their electrolytes and renal function?
I do 1 to 2 weeks.
When you start someone on chlorthalidone, are you ever starting that along with potassium? Or are you modifying anything in their diet to tell them, make sure that, now that you're on this medication, you can have low potassium, low sodium? Do you give them any kind of dietary changes when you're starting them on these agents?
Well, first of all of your hypertension patients, you should be talking about the DASH diet, right? That should be stop telling them to cut out the sodium in their diet, because nobody does that. Nobody can do that. And it's not all that effective for hypertension. Get them on the DASH diet, and the DASH diet is rich in potassium, right? So it's a good, healthy diet with a lot of potassium in it. And that should cover a lot of that. And the other thing is, my population is probably different from yours. My population has an average GFR south of 35, right? And so I don't see all that much hypokalemia, and I usually will wait till it reveals itself before I start them on a potassium supplement. And I kind of like the hypokalemia to give me room to titrate up their ACE inhibitor.
I see. Another thing that I'm constantly running into, leg cramps. Tell me you have the magic cure. All my patients it seems like if they're on an ACE, if they're on a thiazide or a loop diuretic, they are going to complain of leg cramps.
Leg cramps, of all things.
What have you tried that doesn't work?
Well, I tell them stretch before bed, make sure they're getting enough hydration.
Massage.
Sometimes I'll tell them to do Stewart's trick of drinking almond milk or eating some avocado. Some people ask me if they can take over-the-counter magnesium supplements, 4 ounces of tonic water. These are these are all the things. One today,
Newt.
this is legitimately happened to me today. An 83-year-old guy goes, they gave me this at West Point, and it was like a pill bottle from like before 2000, and it had 300 some milligrams of quinine.
Nice.
And he's like, should I take this? And I was like, no, sir.
What was the expiration date on that? Like 1992?
It was like,
the
it was
best.
literally more than 17-year-old quinine. And he was
Whoa.
asking me if it was safe for him to take
I'm going
it.
to say no.
Yeah.
So forever, I was with leg cramps. I was measuring calciums and potassiums and giving calcium and potassium supplements, and they would come back and say, "Doc, it didn't work," and nothing. And I was frustrated. And then I had a patient with Gitelman syndrome. Right? You remember Gitelman syndrome? It's like a congenital loop diuretic. These patients have an abnormality. A loss of function mutation in their distal convoluted tubule. So it's like they were born on high doses of hydrochlorothiazide. And so they all have hypokalemia, hypomagnesemia, and low blood pressure. And these patients are tremendous salt fiends. They just love to eat salt, right? Because they're salt wasters by nature. And they told me, yeah, when I get cramps, I take pickle juice.
Pickle juice.
Yeah, I was like, really? And so I started advising at first my dialysis patients, because they get terrible cramps, to take a tablespoon of pickle juice, and it worked like a dream. And now I use it for my diuretic patients. Now it is a significant sodium load, so you don't want them to be taking it all the time. But for that, when they get these Charlie horses in the middle of the night and they can't sleep, you hit them with the pickle juice. And I've read some articles since then that have looked at this. This is a real thing that's been examined for athletes. And they think it's actually not the sodium load and changing the osmolality of the body, that there's something about this very pungent flavor when it hits the pharynx. It changes something centrally that relieves the cramps.
Have you tried using that for restless leg syndrome? Just
I
curious.
do. Yeah, I have.
And have you had the same kind of results?
I'm not so impressed with my RLS.
Wow, that's great. That's great. I can't wait to try that. I'm so glad I asked that.
Well,
I thought you were going to be like, "Sorry, kid, I got nothing for you."
Or boy.
Well, and make sure you maximize the placebo effect, right? Make sure I don't normally tell my patients this, but this is a little secret that I was told. Or if you can have a good backstory, you want to increase the theater level to level 10.
I'm curious. Did he just do that to us?
Yes, I did.
Okay. Another back to me giving my patients hyponatremia, osteoporosis, and breaking their legs.
That's good, Matt.
Which I feel terrible about. When
thiazides are good for osteoporosis, that's what I've been told.
Yeah, let's talk about thiazides and protecting against osteoporosis.
That way we can make them feel better.
Yeah, that's great. So what we said about hyponatremia is true. You don't want to leave these patients with hyponatremia. But in all the big trials, these patients would be dropped from the thiazide arm if they developed hyponatremia. So, and that's what we should do with our patients, right? We should get them off the drug that causes a side effect that's going to cause osteoporosis and falls. But that's not everybody. Most patients take this drug with no problem when their sodium is fine. In those patients, which is the vast majority of them, this drug will lower their urinary calcium. And where was that calcium coming from? To some degree, it was coming from the bones. And so by lowering their urinary calcium, you are increasing the calcification of their bones. And we've got data that shows increased bone mineral density. And we've got data that shows decreased fractures. There was a meta-analysis, a Cochrane meta-analysis, I'm reading the methods or the results, and they said we had 400,000 patients. I had to go back and reread that. I had never seen such a large number. Now that was observational data, but in observational data, 400,000 patients, 24% reduction in fractures. We're not talking about bone density. We're talking about real outcomes here. And then we were talking about the All-Hat trial. All-Hat trial is a huge trial. I think it's 45,000 patients. And in the All-Hat trial, they went back. Again, it wasn't part of the primary outcomes, but they went back and they looked at, well, how many people had fractures? And there absolutely was a significant reduction in fractures on the chlorthalidone. And that's a randomized trial. That's going to be as high quality data as you're ever going to get. And so I believe that this is really good for these patients that have a low bone mineral density.
Hopefully my patients, since they're on a thiazide, maybe it's balancing out me letting their sodium drift down. It's like one patient that I was specifically asking about, who I'm going to have to call tomorrow and pull her off her thiazide. But I'm glad. This is why we do the show. I gotta figure out what things I'm doing wrong. So I appreciate you being honest when I asked that question. Stuart, I know that you wanted to talk a little bit about resistant hypertension.
That's right. So one thing that we do quite often, and this is actually as a born out from the Pathway 2 trial, is our patients that are on maximal dosage for multiple antihypertensives and are still not at goal, we've started to put them on spironolactone, starting around 25 milligrams and titrating up to 50 if they can tolerate it, based on electrolytes and I guess gynecomastia, I suppose, as well. So what is your take on using spironolactone as a drug for resistant hypertension?
So I'm going to ask you, is it as magic in your hands as it is in mine?
It actually really does seem to have been that way for multiple patients, but I don't know. What do you think?
It's absolutely true that this is one of the great secrets to resistant hypertension. This drug, aldosterone antagonist, and it's actually really all of the potassium sparing diuretics. So there's really good there's really good data also on amiloride. At least the data that I saw was specifically for African Americans, which is most of my resistant hypertension population. But spironolactone, eplerenone, amiloride, these are great magic bullets for that resistant hypertension. And oftentimes they'll come to me uncontrolled on 5 or 6 drugs, and I'll get them on spironolactone, and I'll be able to peel off those drugs, and they'll go from 6 drugs to maybe 2 or 3.
Yeah, I've seen this happen. I've seen this happen many times.
Yeah, and this is backed up in the literature. There's a lot of literature that supports this. This is the right way to do it.
One of the questions I always ask myself though is, should I be checking a renin to aldo ratio first before I do that, or just put them on it?
So if they're resistant hypertension, right, if they meet the definition, so 4 drugs, including an adequately dosed diuretic, and they're still not controlled, you need to get we'll get to it. You should get the renin or the aldo-renin ratio.
Okay.
Because if they have an aldo-renin ratio greater than 20 and an aldo level greater than 14, they meet the definition of primary hyperaldo. And if this is a patient that could tolerate major abdominal surgery, you need to look for a functional adrenal adenoma. You need to make sure they don't have Conn syndrome, because you could cure them with an adrenalectomy. Now, if it's your 82-year-old patient, you're never going to send them for this surgery. You don't need to worry about that.
Oh, you haven't seen our patients yet.
Well, okay. If you had 82-year-olds that can tolerate abdominal surgery, go to it. I mean, I've heard things about Texas. I've never believed them. But if it's a patient who can tolerate surgery, that's exactly what you want to do. You got to check that aldo-renin ratio. If that ratio is too high, so the ratio greater than 20 with an aldo level of more than 14, you have to have that second part, because some of these renins come back like 0.01, and also the ratio shoots up really, really high. They need to have a high absolute aldo level also. Then you need to confirm it by trying to suppress the aldo. So you need to make sure the potassium is corrected, and then you sodium load them with a liter of saline, and then you repeat the test. If they're unable to suppress their aldo with normal potassium and a full sodium load, then you send them for a selective adrenal vein sampling. And when you do this, the side with the adenoma will have a sky-high aldo, and the contralateral side will be completely suppressed and have no aldo. Once it lateralizes, then you go take it out. And it's amazing that, like, the patient who's had hypertension for 15 or 20 years goes from 4 drugs and poor control to 1 drug or no drugs. It's amazing.
Before I tag you in as the nephrologist for this, what workup do you want me to have done for secondary hypertension? I find that because if the patient's on an ACE inhibitor or thiazide or things that could potentially mess up this testing, how do you handle the logistics there?
So I think we're a lot more liberal than we used to be. And some of the old textbooks say you have to stop all these drugs before you do it. But the true evidence-based studies that have done, population studies that have looked at this, is as long as they're not on an aldo antagonist, you don't need to worry about it. And you can just do the aldo-renin ratio on all the drugs except for the aldo antagonist.
That is very good to know, because I am probably underusing that test, because I was kind of like, well, I'm not going to take the person off all these medications and try to, like, I don't know, what do you slap them on, like hydralazine and clonidine or something like that in the meantime, so that you're not messing with the renin system. But okay.
The one that kills me, I had a young woman, and she came in, it looked like clearly resistant hypertension. She had a low potassium. I was sure it was primary hyperaldo. And she was in that ER section where they can stay overnight for a night. And I thought I could give her spironolactone, an inexpensive drug, and control her blood pressure. But the right thing to do is do the test. So I told her, hey, I want you to follow up in clinic. We're going to set you up. We're going to try to suppress you and see if this thing still, check a renin-aldo ratio or aldo-renin ratio. And I gave her my card, and I sent her home, and I didn't see her for 5 or 6 years. Turns out she'd lost her job. She'd lost her health insurance. And the next time I saw her, she needed to start dialysis.
Oh, man.
And it just killed me. I just thought, if I'd given her this inexpensive drug, spironolactone, I'm sure I would have fixed her blood pressure, and she would be doing fine. And she's still my dialysis patient. Like I still see her, and that mistake just it haunts me. I really think I did a huge disservice for her by just saying, hey, the right thing to do is, got to do the test. You got to check this, right? And especially in a young woman, that she was a real setup for adrenal adenoma.
But who knows if she would have taken it, and I'm sure she saw other physicians in that 5 to 6 years, and someone else could have potentially started her on that. So I don't know. It's totally on you, but I have a huge guilt streak in me too, sir. So I probably would have felt the same way.
Well, he lays us up bare. I've got one quick question about spironolactone. How real of a concern is spironolactone's anti-androgen effects?
I think at the doses that you were talking about, at 25 to 50, you're just not going to see it very often. Now, remember, it's a competitive inhibitor. So if patients have very high aldo levels to begin with, you're going to need to use more of that drug. So when you get a real primary hyperaldo, you may be needing 100 milligrams or 100 milligrams twice a day to control their blood pressure.
Wow.
And at those doses, you're going to see it. But I do see it. I have had a number of men at 25 milligrams a day develop nipple tenderness. And I always tell them in advance, I kind of feel like it's such a weird side effect that if you don't prep them for that, they won't even mention it to you. Right? They'll never make that association with the drugs. I always make sure I tell them in advance, and then I tell them, and then I ask them at subsequent visits. Usually it's so weird that they remember it and they'll bring it up if it happens. And I've switched those patients to eplerenone, and I don't think it's as good a drug, but it definitely doesn't have the side effects. They tolerate eplerenone with no trouble.
I want to jump. I think that we're probably running out of time, and we've taken a lot of your time. One of the last things I definitely want to make sure we touch on, I've been hearing a lot about this, people saying, okay, when furosemide stops working, you got to go to bumetanide or torsemide, because when patients with heart failure have gut edema, they don't absorb furosemide unless you're giving it IV. So, and also I would like you to comment on House of God dosing of furosemide, if you would.
Okay, so the proper dose of furosemide per house of God, I think it is rule number 6, if I remember correctly. Wow. It is age plus BUN equals Lasix dose.
Yes. It's like my favorite thing to do on rounds is if I suggest to the resident, they're like, we gave 40 of furosemide, nothing happened. I said, House of God dosing? And usually that works when you do it.
Looks like it's rule number 7.
It's actually rule number 7.
You're really, really close.
Okay, so what about this gut edema thing? Is this real? And should we think about the loop diuretics differently when we're prescribing them?
So when I was a resident, we were a site for a randomized controlled trial of torsemide versus furosemide oral administration for heart failure. Now, it was open label, and when that study got published, it did show a significant reduction in hospitalization, right? No difference in mortality, but you wouldn't expect that, right? You'd expect people that got decompensated heart failure would show up in the hospital and they'd all get IV drug and then they'd be fine. But in terms of keeping people out of the hospital, torsemide was more effective than furosemide. And I think that old rumor that you get better absorption, better bioavailability really does hold up. If you look, there's a great review of diuretics from 1998 in the New England Journal of Medicine. Author is Craig Brader. And he was our program director when I was a resident. And there's a chart in there which gives you the bioavailability. Remember, the bioavailability is the ratio of an effective oral dose to IV dose. So a drug like Cipro, which has great bioavailability, has a bioavailability of 100%. There's really no advantage to giving Cipro IV. And then a drug like vancomycin or insulin has zero bioavailability. You can give all you want orally, none of it's absorbed. And the bioavailability of Lasix in that chart is listed as 10 to 100%. Right? You either need to multiply the oral dose by 10, or the IV dose by 10, or by 1, somewhere in between there. And the bioavailability of both Bumex and torsemide is listed as 80 to 90%. So very reliable oral dosing. And that's been my experience also. So, and then the other advantage that torsemide has is its half-life is about 2 or 3 times as long as furosemide. And so you can get away with once daily dosing with torsemide for antihypertensive effect that you really can't with furosemide. So I'm a believer in the differences on this class.
So House of God probably had it right. They're probably doing BUN plus age for an 80-year-old who's absorbing 10% of it. That's probably why you need to use so much. So maybe it works.
The other aspect of that calculation is that, remember, these drugs, all the diuretics, work on the tubule side. They don't work from the blood side except for spironolactone. They have to be filtered for them to be active. And so as your GFR falls, you need to compensate by going up on the dose, which is totally counterintuitive, right? We're always used to renal dosing being lower doses in renal failure. Well, not when it comes to diuretics. It's higher doses in renal failure. So that's your age plus BUN. What I use creatinine times 20 to get my Lasix dose.
And is that the Topf method, or did you name it?
No, I did not name it. I did not come up with it. Some resident smarter than me taught me it.
Okay.
So I always kind of thought it was because furosemide is insoluble in water versus torsemide is actually water soluble. So I always thought that it had to do something with absorption across the GI tract due to its solubility, not necessarily just. I mean, that's the way that I think about it.
Right. Well, I think in terms of oral absorption, I think you're exactly right. The higher dosing in renal failure is not from the oral absorption. That's from at the kidney, at the level of kidney. Now, these drugs, I did misspeak because I said that they were filtered. All of these drugs are highly protein bound, and they're actually secreted in the proximal tubule.
Right. Another question that I had was for dosing Lasix. So I was speaking to one of the nephrologists that I work with, and he was telling me when I sat down and went over some of these before we were going to talk to you, that if you dose Lasix once daily, then you end up having a sodium retention in the evening time when you would typically dose or redose Lasix, because it's just the way that your body's responding to the natriuresis with the first dosage of Lasix. Is there some clinical implication to this sodium shift, this diurnal sodium shift, if you don't redose sodium twice daily versus once daily?
Right. So, I mean, I give a lecture on dealing with diuretic resistance. And so there's two patterns to diuretic resistance. So one pattern is you give them a dose and they just don't pee. And that needs to be overcome by increasing the dose. And there's another pattern where you give a dose and they make great urine, but you come back 24 hours later and the total urine output's just not that impressive. They peed a lot for those 2 or 3 hours after the dose, and then they didn't pee at all for the rest of the day. And that's because the patients that we're giving these diuretics are naturally very sodium avid. And as soon as the drug wears off, they're going to become sodium avid again. Mm-hmm. And so when you see that pattern, you need to increase the frequency. And so if you look at the pharmacokinetics, I mean, Lasix really should be a Q6 hour drug. It lasts about 6 hours, right?
It's almost like, but isn't it cruel to give a patient Q6 Lasix because it's just going to be around?
It's wonderful.
They're going to be waking up in the middle of the night. I guess that's why I tell patients take it at 8 a.m., 2 p.m., something to that effect, so that hopefully it's out of their system by the time they're going to bed.
Yeah, I mean, or you give them torsemide and it's longer acting, and so you don't have these peaks and troughs so much.
We want to wrap up, but just some things to kind of recap. You were saying that for patients with renal failure, it sounds like you're kind of talking about the Lasix threshold, which is where you give a dose. Like, let's say this happens all the time. Patient comes in, they're an older patient. They get 20 milligrams IV Lasix instead of 40 or 80, and they get 20. You come back within an hour, they really haven't started to pee at all. So what do you do there? Do you wait until that dose wears off? Do you give another 20, or do you just give them the bigger dose on top of the 20 because the 20 didn't do anything? I guess I'm kind of asking about stacking of doses.
Yeah, I don't worry about stacking. The drug doesn't last that long. I go with 40 milligrams. They don't pee within an hour or two. Just double the dose and go try again.
So give the dose that you thought you were going to give. Okay. And then also, if you're using Lasix as a blood pressure medication, obviously, because of the half-life, not an ideal blood pressure medication, but is it true that it really needs to be done twice daily in order to get that effect for most patients?
Yes, it is true. You need to do twice daily or torsemide once daily.
Dr. Topf, I mean, this is a lot of great information. I am gonna, I'll let you know when this is gonna come out. Probably it'll be a little while because we do have like five or six episodes that we've recorded right now that we're at weekly episodes, but it'll probably be next month sometime that this will come out. I wanted to ask, we've been talking about blood pressure, diuretics. Can you give us a couple take-home points that you want our listeners to really remember?
Okay, take-home points. One, if you're going to be using a diuretic, a loop diuretic, you want to dose it appropriately. So make sure that Lasix times creatinine times 20 for Lasix dosing. Cut that in half for torsemide. Use Lasix at least twice a day for heart failure. Torsemide you can use once a day. Bumax, very short half-life, even shorter than furosemide, which means it's great in the ICU, right? Short half-life means very quick onset of action. So when you absolutely positively have to have that urine bag filled now, Bumax is your drug, okay? Thiazides, always use chlorthalidone, never use hydrochlorothiazide. Make sure you check their calcium, their potassium, and their sodium. Hyponatremia is a real problem, and those are the ones that get sick because the sodium drops very fast. In resistant hypertension, be quick. I think you should be quick to reach for the aldo antagonists. I'm a big fan of spironolactone, 25 milligrams daily. Be careful about that potassium, especially if they have CKD stage 3 or they're elderly. They will run into hyperkalemia, so you'll want to watch that. And then new piece of information that's actually pretty cool is if you're dealing with nephrogenic diabetes insipidus, letter to the New England Journal of Medicine showing that acetazolamide is wildly effective at reducing their 24-hour urine output. The textbooks tell you to use a thiazide type diuretic, and this acetazolamide just beats the pants off of it.
Great. Thank you so much. Sir, any questions for us before we let you go here?
I think the stuff you're doing is great. I think you guys, I've been just it's the whatever that new curbsiders pops up on my app. It's the first thing I read. I listen. I love it. You guys are doing great work.
Awesome.
Yeah, well, we feel absolutely the same about you, sir. Very, very glad that we've met up with you via social media, and would encourage our listeners to start following you on social and checking out your blog and your book.
And I want to see you. I want to see you guys in Neph Madness. I'm going to be looking for your entries. I want to see some curbsider entries there. Okay,
All right, we'll see what we can do.
That sounds awesome. All right, sir. You have a great night.
You take care.
All right, take
Bye.
care. Bye.
Bye.
This has been another episode of The Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
You can find show notes along with links to any articles, books, websites, or apps mentioned on the show at thecurbsiders.com/podcast. You can also sign up to receive our monthly newsletter summarizing key tools, tips, and tricks for your practice at thecurbsiders.com/knowledge food.
Practice alliteration, I see.
We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your input. So please subscribe, rate, and review the show on iTunes, or send us an email to thecurbsiders@gmail.com. You can recommend a future topic or tell us what you love or hate about the show. And finally, you can follow us on our page on Facebook, Instagram, and Twitter at The Curbsiders. Until next time, I've been Dr. Matthew Watto.
Here with Dr. Stuart Kent Brigham and no Paul. Good night.
Paul is sitting in a dark room with one of his cats watching his 150th movie of the year.
He's ahead.
Sorry, I'm losing my train of thought here.
That's okay. I pointed at you and you weren't ready.
I was
You were writing something.
no, I was writing down diuretics, poison to the kidney, and I was thinking, I was like, how do I want to tackle this?